Aloha everyone, Dr. Faye Reynaldo here, and we will be continuing our lecture from yesterday. We stopped here. So we were talking about drug interactions and we stopped at metabolism. So there's still the excretion part. So we'll start with that. So some drugs can increase or decrease excretion of drugs from the kidneys. So, for example, if a drug can decrease a cardiac output to the kidneys, then that will also decrease the glomerular filtration, which would mean decreased or delayed drug excretion. If a patient is taking a diuretic and combining it with another drug, diuretics will promote water and sodium excretion. So there are electrolytes that could be lost when a patient takes diuretics. So this could actually alter some action in drugs. So for example, if a patient is taking a diuretic and is also taking digoxin, then if a patient is taking digoxin, they need to have adequate potassium levels, because if they have hypokalemia, they could get digoxin toxicity as well as some types of dysrhythmias. So it's important for us to monitor patients with any combination with diuretics. And then for drug interactions, you also have the pharmacodynamic interactions. And there's different kinds of effects. So the first effect that I'd like to talk about is the additive effect. So in additive effect, you have two similar drugs, which means that it's either they have a similar pharmacological effect. That's what you plan to have. Like, for example, the goal is to lower the blood pressure of your patient. So there's two different classes of hypertensives. So that's what you mean by two like drugs. If they are administered in combination, then the response will be increased beyond what either could produce alone. So this is like a 1+1. So the sum of the effects of the two drugs. So additive drug effects could be desirable or undesirable. So for example, you have your diuretic plus a beta blocker. Both are different kinds of antihypertensive agents. So we could combine this because we want a much more stronger or more pronounced blood pressure lowering effect. Another one is your hydralazine and your nitroglycerin. And so with both of these drugs, they are vasodilators. And so with this combination, you will have a severe hypotensive response because there's a severe vasodilation effect. So this could actually lead to potential problems of patient safety, such as dizziness and fainting, which we will know as orthostatic hypotension. We'll talk about that more. There's also the synergistic effect. So with synergistic effect, it's kind of similar to the additive effect, except these two drugs are not alike, which means they don't have the same purpose or the same desired physiological response. So these two or more unlike drugs are used together to produce a combined effect, and the effect makes a drug work better. So, for example, you have the antibacterial ampicillin. And so, ampicillin is a penicillin-like drug. It could be deactivated by beta-lactamase, which is an enzyme. And so, if you add sulbactam, which is a bacterial enzyme inhibitor, it's a beta-lactamase inhibitor, the addition of your sulbactam to the ampicillin will actually increase the delivery of ampicillin because it prevents ampicillin from being deactivated. Another one is penicillin. So penicillin, another antibacterial drug. In some cases, if you want a stronger effect and a long-lasting effect of penicillin, such as in the case of syphilis, some providers would add probenecid, which is weird because it's an anti-gout medication. But probenecid, if you combine it with penicillin, actually inhibits the tubular secretion of penicillin. So this will increase penicillin plasma levels and will strengthen the effect of penicillin. So it shows a 2 to 4-fold elevation of penicillin plasma levels. So that's a very good example of synergistic drug effects. In other cases, it could be antagonistic, which means that one drug will block or reduce the effect of the other. So this could be desirable or undesirable. So for example, it could be desirable, such as in the case of morphine sulfate, if your patient had an overdose or maybe toxicity, then we give naloxone Narcan. And then that would, prevent the patient from having more serious complications. Or if a patient has heparin overdose, then we give the antidote, which is protamine sulfate, and that will prevent hemorrhage or bleeding from occurring. Another is your drug-nutrient interaction. So some drugs can interact with food, or food could interact with drugs. So either food could increase, decrease, or delay the body's pharmacokinetic response. So a very good example of this is the antidepressant monoamine oxidase inhibitor, or what we call MAOI inhibitors, or MAOI antidepressants. So combination, if your patient eats tyramine-rich foods, which are usually in fermented foods, such as aged cheese, beer because the yeast is fermented, yogurt, banana, sour cream. If you combine, if your patient who is taking a MAOI inhibitor eats a tyramine-rich foods, it will result in hypertensive crisis. And tyramine is a potent vasoconstrictor, and that's why it increases the blood pressure of the patients up to like 210 over 180, something like that. So it's really, really serious. So for patients taking MAOI, we tell them avoid these foods. Another one is your grapefruit, and so about 50% of the drugs interact with grapefruit, because grapefruit is a drug, is an enzyme inhibitor, and we talked about enzyme inhibitors during the lecture. So it affects about 50% of the drugs on the market, so this could actually cause serious adverse drug reactions. So sometimes we even tell a patient, you know what, avoid grapefruit as much as possible if you're taking a lot of drugs. Drug laboratory interactions. Again, as I said earlier, a drug could interfere with some clinical laboratory testing. It could either lead to like false positive or false negative results, and this could lead to missed or erroneous clinical diagnoses. So we also have to be aware of that. There's also the drug-induced photosensitivity. So with drug-induced photosensitivity, so drug-induced photosensitivity, it's a skin reaction caused by exposure to sunlight while taking a medication. And usually this is because of exposure to ultraviolet light, again, with exposure to a drug. There are several drugs that have photosensitivity reactions. It could be photoallergic or phototoxic. So photoallergic occurs when a drug undergoes activation in the skin by ultraviolet light that is more allergenic than the parent compound. This is usually a delayed hypersensitivity reaction, which means that you may take the drug right now and get exposed to sunlight, you don't get anything, and then the next time you get exposed to the sunlight, you'll have a photosensitivity reaction. Or if it's phototoxic, so it actually undergoes a photochemical reaction within the skin to cause damage. This is not an immune mediated type of reaction. So with this, it's a rapid response, which means that after 2 to 6 hours of sunlight exposure, you'll get sun damage. So in this case, our nursing intervention for patients who could be at risk for photosensitivity is that we tell them to cover up. So, long sleeve shirts, bring an umbrella, use the umbrella, protect themselves, use sunscreen. So that's really the nursing intervention for drug-induced photosensitivity. And again, as I said, there's a list of drugs that can cause drug-induced photosensitivity. Very common ones include with antibacterials, tetracyclines, and fluoroquinolones, as well as sulfonamides. Okay, so as I said yesterday that we're going to talk a little bit about pharmacogenomics, and I think I kind of talked about it now, but yesterday a little bit. But really what we're looking into is ethnomedicine. So ethnomedicine is also about folk medicine or traditional medicine. It's a part of medical anthropology that really looks at how people and their different cultures conceptualize health and illness. And ethnopharmacology is one kind of ethnomedicine, which focuses really on the use of herbs, powders, teas, or any drugs as a healing remedy. So ethnopharmacology really is about sort of like complementary and alternative medicine. What do some ethnicities, races, cultures use to treat illnesses or for health purposes? But what's really important regarding this ethnomedicine is that, again, with your genomics, the current type of genomics that they're doing is by race and ethnicity, although we're now focusing more on individual differences or variations of the genomes. So we just need to understand that right now we're at the level of being able to determine some pharmacogenetic differences in drug responses at the ethnic and race level. So here are some terms you may want to understand. And again, as I said earlier, the CYP450 system, which is the liver system, is really where liver enzyme system is where most of the pharmacogenetics affects the drug response. And here's a table. You can find this in your book, table 3.1. It provides like a picture of like the different biologic variations for different races and cultures. Okay, for the next few sections, we're going to talk about pediatric pharmacology and how that's different from, general pharmacology, or how it affects pharmacokinetics and pharmacodynamics. But one thing you need to know is that there is limited research available related to dosing protocols, safe practices, key assessments, as well as nursing implications in pediatric pharmacology. And this is because it just recently was mandated, or not even mandated, but it actually encouraged that pharmacologic research or pharmacotherapeutic research should also involve children. So, but at the same time, we want to keep our patients safe. So you just need to understand that there is limited evidence-based information or research related to drugs in the pediatric populations. And if you use the studies that were done on adults, this could result in serious errors. So there are also some reasons why research is limited. So first, there's a lot of research risks, and second, there's also difficulty in obtaining informed consent because you have to have two levels, the parent and the children. Usually parents and guardians are very reluctant in providing permission for children to participate in studies. There's also fewer investment of resources on pediatric drug research because the market for pediatrics is much smaller compared to the adult population. There's also limitations in drug labeling. So again, because not a lot of drugs have undergone clinical trials for pediatric use, a lot of the drugs have not been approved for pediatric use. or else research has only been done and it's mostly smaller studies. So the Pediatric Research Equity Act, we talked about it yesterday. This is a recent law, and it requires drug manufacturers to study pediatric use. And also it requires them that if they have drugs that have off-label uses, then they need to provide that information. So off-label means that the drug is being used for a purpose, but it has not been approved by FDA. And there are some patient safety notes from your textbook. I'd like for you to read through them. They're really they're easy to understand, and it relates to how to prevent drug administration errors in pediatric pharmacology. So this includes, for example, proper calculation of the drug doses. If you're doing your modules right now, you will notice that there's a specific module on pediatric drug calculations. So please read through that. I think it's in the first few pages of the Pediatric Considerations chapter. Okay, so pharmacokinetics related to the pediatric population. There are significant differences that exist in drug pharmacokinetics for pediatric patients versus adults, and this usually comes from differences in body composition as well as organ maturity. The differences are much more pronounced in the neonates and infants, and as the child grows older, it becomes less significant, because as they grow older, some of the organs or body composition is more similar with the adult. So for example, with absorption, you already know what absorption is, but when it comes to age, absorption will be less developed in the neonate and infants, and so there should be a change or a reduction in dosage probably in your neonate and infant population. So because of the fact that they will have, well, it's either that you increase it or you have a reduction in dosage, and then maybe the administration will be more different. And that's why most of the drugs that are available for neonates and infants are already in liquid form, because it's already dissolved or it's already in a dissolution state. As children grow and develop, absorption of drugs will be more effective. It will be more similar with the adult population. With your adolescents, though, you have to kind of think about their lifestyle or their way of life. So some of them will have poor nutritional habits. There may be rapid changes in physical maturity as well as hormonal differences. And all these factors could result in a change in the drug absorption rates, usually a slowing down. Other significant factors that could affect absorption includes hydration status, any presence of underlying disease, as well as GI disorders. So if they're taking oral drugs or enteral medication, you have to know the gastric pH at birth for neonates is alkaline, and then it increases in acid production by the neonatal period, so the first 28 days, and then it will reach adult levels around 2 to 3 years. So remember that most drugs are much more rapidly absorbed in an acidic environment or an acidic environment. So that means that these differences in pH could hinder or enhance their drug absorption. Gastric emptying and GI motility are unpredictable in neonates and infants. If you will notice, they get, if they drink their formula or they drink breast milk, they absorb it really fast. So there's a fast gastric emptying, and so it's really unpredictable. It approaches that about the adult levels at 6 to 8 months. Gastric emptying could be affected by feeding, and as observed, breastfed infants have faster gastric emptying than formula-fed infants. So again, this is all related to that unpredictability of GI motility in this population. Their intestinal surface does not reach that of the adult levels until 20 weeks. So reduced surface means lesser drug absorption. They also have inadequate production of bile salts and pancreatic enzymes. So this will reduce the absorption of your lipid-soluble drugs. Intestinal or gut microbial colonization begins in the first few hours after birth, and it's very slow to reach adult levels. In fact, it doesn't reach adult levels until adolescence period. If we're giving them subcutaneous or intramuscular drugs, then there's also the difference in level of peripheral perfusion and effectiveness of circulation that could affect the absorption of the drug. So some conditions that could alter perfusion in a younger child, they may be more likely to get dehydrated. They're more likely to be exposed to cold temperatures or feel cold. They may also have alterations in cardiac status. So for one, the skin of the infants and young children is actually thinner than that of the adults. And then their ratio of body surface area is much higher compared to adults. So which means that it may be drugs may be much faster to be absorbed, and they could have drug accumulation. So this is a good picture of the body surface area of a toddler as well as a school-age child, and then adolescents. Distribution will be affected by several factors, including body fluid composition, body tissue composition, protein binding, effectiveness of any various barriers to drug transport. So for distribution, neonates and infants will have more water proportion compared to that of adults. So 75% water, the body is made up of 75% water compared to only 60% in adults. So increased body fluid proportion, which actually results in greater fluid volume distribution rate, and this will actually lower drug concentration because there's more area for the drug to be distributed in the bloodstream. So until about age 2 years, a pediatric patient may require higher doses of water-soluble drugs to be able to achieve therapeutic levels. So, they also have higher levels of extracellular fluids, so they're more likely to get dehydrated, and again, this would result in a change in the distribution of the water-soluble drugs. So here's a picture of, for fetus, it's 90%, newly born 80%, child is about 70 to 75%, organic water. Neonates and infants have fat stores with an increased ratio of water to lipids, so this also alters the distribution of some lipid-soluble drugs. So, for example, anti-epileptic drugs are lipid-soluble, so the therapeutic level may not be achieved, so close monitoring, especially for narrow therapeutic index drugs, is necessary. We want to make sure our patients are safe. They also have decreased protein concentrations, neonates and infants. So with fewer protein receptors, they have higher levels of unbound or free drug. This will increase their risk for toxicity. In newly born infants, they will have high bilirubin levels. These bilirubin molecules, they could bind with protein receptors, which will make it more likely that they will have a decreased protein receptor sites. Again, it will displace drugs from the binding sites, allowing for more free drug or unbound drug, resulting in drug accumulation and toxicity. So with this, the implication is that dosages may be decreased for highly protein-bound drugs, and that we need to closely monitor them to avoid any adverse effects. The BBB, any anatomic barriers are relatively immature, so there's a possibility that the drugs could pass into the central nervous system. In short, it could result in toxicity. So for metabolism, it greatly depends on the maturation level of the pediatric patient. Again, remember that metabolism is primarily done in the liver, with the kidneys and lungs could be helping out. But infants have a reduced hepatic blood flow as well as drug metabolizing enzymes. It doesn't reach adult levels until 1 year of age. So with that, what happens is that they could have increased drug accumulation because drugs are not being deactivated fast. Also, for the enzymes, they don't reach adult levels until age 11. And the different P450 systems, because there's different subsystems like CYP1, CYP2, and CYP3, they will develop at different rates, so it will really vary. So what do we do with this situation? So we just have to have close monitoring of drugs, and we have to evaluate their therapeutic effects or their possibility for toxicity. Kidneys are the predominant means of drug elimination, but for neonates, the glomerular filtration rate is 30% of that of the adult. It's only by 12 months that it reaches adult levels. So, which means that if we're giving drugs to children, we have to monitor their renal function as well as their urine flow. Again, careful monitoring is always what we're trying to say in these situations. So with the pharmacodynamics, the effect is always relative to how much drug was taken into the body, how much drug was absorbed, distributed, metabolized, and excreted. And so the pharmacokinetic processes of the pediatric patient really determine how the drug will start taking effect in the body. Like when does the onset begin? When will it reach its peak? So at this point, it's like there's a lot of variations, and there's so many variables involved. So the nursing implications for all of this is that we have our role as nurses is to really closely monitor patients for our desired effect, which is the therapeutic effect, but at the same time, adverse reactions. We may need to do more laboratory testing so that we can ensure that our patients are reaching those therapeutic levels and that the pharmacotherapy is not suboptimal. However, we also have to understand that there's limited research on this, and the therapeutic levels that have been set are based on adult studies. Also, when we're doing our dosage calculations, we need to be much more, even with adult patients, we need to be very careful that we're using the correct calculations, but more so with the pediatric dosing, because again, any small change in the dosing, if you increase it or if you decrease it, it could lead to drug toxicity. If you decrease it, it could lead to suboptimal therapy. So, proper calculation of pediatric dosages is needed. There are pediatric dosings available for about 450 drugs because of the BPCA law and the PREA law. If there is no pediatric dosing schedule, then usually dosing for kids will be based on approved protocols in the institution or maybe available research studies and provider experience. And most of the time, pediatric calculations will be based on weight in the child's weight in kilograms or body surface area. There are some here are some samples of formulas for pediatric dosing, but we're not going to talk about that. You're going to cover that in your modules. Okay, and then pediatric drug administration. Whenever we're going to administer drugs to our patients, we have to consider any of their developmental and cognitive differences, because these differences will be used to determine, well, how are we going to include the child in the administration of the drug, because we always partner with our patients, right? So the principle for pediatric drug administration is always to make sure it's family-centered care. We are making sure that we provide proper teaching, we involve the family, we ensure safety. And so whenever we are caring for our pediatric patients, family members, caregivers, and the patient should always be involved. Patient teaching as well as administration. Because we're not always going to be there for our patients, we need to involve the family members and their caregivers. They're in the best position to be able to evaluate how effective the drug was, and also provide us information related to side effects as well as adverse reactions, especially for younger kids. The caregivers definitely need to be involved. As they grow older, we still provide teaching to the family members and the caregivers. However, we also provide more responsibility towards the child or the adolescent, right? Okay, so when we're providing patient education, we need to make sure it's at a developmentally appropriate level. So let's say, for example, with infants, our goal for family-centered care is to maintain safety and provide care with as much comfort as possible. So drug administration at this point will definitely be on the family member or the caregiver. And so with drug administration, we may have to enlist their help. Well, not may. They really need to. But at the same time, a major aspect of patient teaching is the psychomotor skills of being able to administer the drug. Toddlers usually could react violently and negatively to drug administration. However, we still need to involve them in this process. So although we're teaching mainly the family member or the caregiver, but to the toddlers we could provide simple explanation of why we're giving the drug. We need to use a firm approach in this. We need to give them a specific reason why they need this, as well as maybe enlisting the imagination of the toddler. Preschoolers are fairly cooperative and can respond well to age-appropriate explanations. So with the preschoolers, providing them a control regarding their drug administration by allowing them some choice in the matter will really help. School age are often cooperative, but they can fear or may fear bodily injury. So again, with this, provide them with even more control, involve them in the process, and then educate them appropriately. Age-appropriate fears related to pain, changes in body image, and injury are common in older school age and adolescent patients. So with this group of pediatric patients, we want to have a good rapport with them, have a really good professional relationship with them, plan the care with them, so involve them in that sense, and then ensure privacy when it comes to administering the drug. We also follow the traumatic care principles. Again, provide comfort as possible. We don't want them to be stressed related to the care that we provide, especially with drug administration. Because the more traumatic it is for them, the more likely that they're going to be non-adherent in the future. So, try as much as possible with the younger children. Avoid separation of children from family members. We need to try and identify if there are any family and patient stressors. Try to decrease their pain by providing them comfort, and always collaborate with them. It's a partnership between us and the patient, as well as their family. So with the pediatric drugs, especially with the younger children, it's much better to administer via the oral route because it's least invasive, it's the easiest to use. If the oral route is contraindicated, then maybe we can use topical, rectal, and parenteral. So especially with parenteral, a lot of people are scared of needles. So, we try as much as possible to put that in the last. Oral, topical, rectal, and then parenteral will be, the sequence of how we could potentially present to patients for their medication. Of course, with the IV route, we have more predictable routes. So in pediatric drug administration, we usually use oral syringes or dispensers, and this should be inserted into either side of the mouth, pointed towards the cheek wall or the buccal mucosa. Alternatively, they could suck drugs from their bottle nipple, as long as the drug has been squirted, has been measured with using the oral syringe. And then with preschool and school-age children, they usually can't be able to inject the oral drugs into their own mouths using the syringe. Pills and capsules for younger pediatric patients, we may need to crush or dissolve the contents of the capsules. Of course, if it's an enteric coated drug, then we can't do that. So we'll have to work closely with the pharmacist to make sure that the drugs could be crushed. In some ways, we could also add sweeteners like jam, yogurt, or honey to make the drug more palatable. However, we have to remember we can't give honey to infants because this increases their risk for botulism. Okay. Small volumes can be used to dilute drugs. So don't give large volumes of water because that could prevent the patient from getting the full dose. For any injections or venipunctures, we can use a topical anesthetic to reduce the pain, and we have different agents such as EMLA, lidocaine cream, or a vapocoolant spray. We also should use non-pharmacological methods of reducing pain such as distraction, diversion, relaxation, and creative imagery, but then this all depends on the cognitive level of the child. Do not give injections or venipunctures to a sleeping child. It will be traumatic for them, and they may not trust their provider, their healthcare provider or nurse anymore. So we need to involve them in the process. Preferred sites for pediatric IM injections is the ventrogluteal and the vastus lateralis because they have more muscle in that area compared to the deltoid. IV sites must also be protected in infants and toddlers. So stocking-like covers or mittens could be used to hide the IV site from infants. And then we should always check the patents given IV site. We don't want infiltration and extravasation. Also with the injection site, provide those cool band-aids to your preschoolers. They love them. So just to differentiate between extravasation and infiltration, Your extravasation is that's a vesicant. It's a vesicant solution, and it became administered into this, it got administered into the surrounding tissue. And so that can cause blisters. So it can cause skin damage. Whereas the infiltration is that it's a non-vesicant solution, but it got into the surrounding tissue and it didn't go into like either the IV or the IM or the intramuscular. Okay. So for your adolescent patients, you need to do age-oriented developmental considerations. It's a highly diverse period of growth and development, affected by so many factors such as nutrition, environment, genetics, and heredity, and gender. So patients may be of different sizes, have different proportions of height to weight. The timing of the development of the secondary sex characteristics could be variable. So there's just so many that we have to consider when it comes to your adolescent population. The variety in the growth and development of adolescents could warrant that their drug dosages would be individualized. Could be based on weight or body surface area, even though they look like standard adults, or their size kind of meets or exceeds standard adults. Also, any hormonal changes in growth spurts at this time may result in changes in drug dosages. Also, there's a lot of changes in metabolic rates as well as sleep requirements that could affect the scheduling and response to drugs, specifically in the area of metabolism. Patient teaching with adolescents needs to be based on their cognitive level and their abilities. So there are some adolescents that, yes, they may look like adults at that point, but maybe their cognitive level is still in the concrete operational stage. So they still may have difficulty understanding concepts of drug interactions, side effects, adverse reactions at therapeutic levels. When they start understanding abstract concepts, then we can be able to start teaching them more complex information. There's also the emotional development to consider. They do a lot of sensation seeking, risk taking. They question a lot of things. They're trying to inform their identity, determining what their identity is. They turn to peer groups. So there's a possibility for high-risk behavior. So we need to assess all of those and determine any potential for drug interactions. As they attain greater levels of independence, self-care behaviors will also increase. So yes, we involve parents, but at the same time, we involve adolescents more. In fact, in some states, it may require that in certain situations, we just deal with the adolescents, right? Okay, so if a patient, if an adolescent patient has chronic illness, how do we facilitate adherence with them? So we could engage their peers in their plan of care for drug administration. Like, how do we make sure that their friends and family members will be part, especially their friends, will be part of their treatment plan? Allow adolescents to make safe choices regarding their care. Be willing to be flexible regarding their care. Set up mutual drug contracts. So it's a level of agreement for of what needs to be done so that they can be adherent to the treatment. And then also allowing the patient to design their own adult monitor, which means monitored by their parents or their caregiver for their pharmacotherapeutic drug regimen. That gives them a sense of control and feels like, I'm doing an adult thing. Okay. So next we talk about geriatric pharmacology, and as I told you yesterday, it is a significant thing because they have a lot of drugs. So with that, we'll have to do more monitoring. So another thing that we have to figure out is that, we need to learn, is that more than 50% of older adults, they use one over-the-counter drug, and sometimes they don't even think of it as a drug. So I think I told you that yesterday also. They also like to take supplements to augment their prescription drugs, and there is that drug herb or drug dietary supplement interaction as well. And a lot of this interactions could result in adverse drug reactions, and and could result in hospitalization. So some physiologic changes that could affect their pharmacology, they have reduced total body water as well as lean body mass, so this could alter the volume of distribution of drugs. They will have reduced kidney mass as well as lower kidney blood flow, which will reduce the glomerular filtration rate. This will result in reduced excretion of the drug. Reduction in liver size and blood flow results in reduced hepatic clearance or reduced metabolism of the drugs. They will also have some decline in physiological processes that maintain their equilibrium. So which means that they're more at risk for adverse drug reactions, such as, for example, if they're taking antihypertensives, they are more at risk for falls because of postural hypertension. They get dizzy, or they may faint. They're also at higher risk for fluid and electrolyte imbalances with the use of diuretics. They are more at risk for bleeding if they take anticoagulants and antiplatelets, more at risk for hypoglycemia, more at risk for GI irritation. So they just have more risks whenever they take medications. Similar with the pediatric population, there's not much studies on the pharmacotherapeutic processes in the older adult, but we know of this of a few things. Their small intestine will have a reduced surface area. They also have slowed gastric emptying. They will have reduced blood flow to the stomach. They will have a decrease in gastric acid production. So although not clinically relevant, some of these have been found to cause problems with absorption of medications such as calcium carbonate. With older adults, we don't use calcium carbonate because it does not work due to decreased gastric acidity. So instead, we use calcium citrate in the older adult population. They also have swallowing some difficulties when it comes to taking the medication, such as swallowing difficulties, poor nutrition, or they may be using feeding tubes as they get older and they get more frail. A decline in muscle mass and fat will result in reduced distribution. With the fat increase, it will increase also the distribution of the lipid-soluble drugs, but it will also decrease their elimination as well as result in drug accumulation because the drug effects will have a prolonged period of action. The decrease in total body water will affect water-soluble drugs, the distribution of water-soluble drugs. A reduction in albumin results in more free drug being available. There's an increased risk for toxicity. Reduction in liver blood flow will result in reduction of the liver enzyme activity. So it could result in reduced drug clearance, decreased first pass, which results in increased drug levels and potential drug toxicity. So we need to assess your patient for liver function. And this is what I was telling you. Alanine aminotransferase, ALT, and aspartate aminotransferase. ALT and AST are your liver function tests. Your renal function tests are your BUN and blood urea nitrogen and your creatinine. Okay. Because they will also have age-related changes in kidney function, their GFR will decline And so this could result in prolonged half-life as well as elevated drug levels, so potential for toxicity. Also, there are some drugs that require dosage adjustment, and the mnemonic for this is Bandcamp, especially for this happens if your patient has chronic kidney disease. So table 6.1 of your textbook, you have your Bandcamp, beta blockers, ACE inhibitors, ARBs, NSAIDs, diuretics, diabetic medications, cholesterol medications, antimicrobials, miscellaneous, as well as psychotropics. So check it out in your textbook. It has your table, so I wanted to present it here. So Bandcamp. For pharmacodynamics, the most common changes that are seen are within the cardiovascular and central nervous system drugs. And then they have a loss of sensitivity in your adrenergic receptors, both for agonists and antagonists. So you may find that with adrenergic drugs, they will have a decreased response. So beta blockers as an antihypertensive or a cardiovascular drug may not be as effective compared to, young adulthood or middle adults, middle-aged adults. They will also have a blunting in compensatory reflexes. So again, as I said earlier, they have reduced responses when it comes to physiological responses of the body to equilibrium. So they're more at risk for falls. They're more at risk for any compensatory mechanisms that could have kept them safe. Reduction in dopaminergic and cholinergic receptors, neurons, and available neural connections. This actually results in reduced response in the central nervous system drugs. They will have reduced blood flow to the brain. They're more the BBB, the blood-brain barrier, will become more permeable, which means that drugs could go into the central nervous system, and this could result in higher rates of CNS side effects, such as dizziness, seizures, confusion, sedation, and extrapyramidal effects. We'll talk about more of that when we get to your CNS drugs. So again, as I said, your patients with who are older adults, they're more likely to have to do polypharmacy. So which means that's the use of more medications that is medically necessary. So there is no agreed number, but usually 5 or more has been found to be a good definition of polypharmacy. The risk factors, again, older adults, females, having multiple healthcare providers, using herbal therapies and OTC drugs as well as prescription drugs, having multiple chronic diseases, and a number of hospitalizations and care transitions. Those are the people at risk for polypharmacy. Polypharmacy has been found to increase geriatric syndromes, which includes a whole list of problems such as cognitive impairment, falls, decreased functional status, urinary incontinence, and poor nutrition. So just a good story. I used to take care of my grandma before she passed away, and she was visiting so many, she had a pulmonologist, she had a cardiologist, she had an endocrinologist, and all of these doctors, they prescribed her an oral anti-diabetic agent and different kinds of oral anti-diabetic agent. And I told my grandma, you know what, Grandma, I don't think you need to take all of those because you're already taking this, metformin. You don't need, the glyburide. And, but she's very adherent. She really, she respects her healthcare provider. And so she said, you know what, I'm going to take them all because they know what they're doing. And so it just so happens that she had, she had a hypoglycemic reaction, and I totally remember this because I was trying to figure out, what's going on, because my grandma wouldn't wake up anymore. She's like, she was okay a few minutes ago. And finally I said, okay, I'm going to take her blood sugar. And it was showing as an error because it was too low. So she got comatose and we had to take her to the hospital because she was taking about 4 oral anti-diabetic agents. Even though I was trying to prevent her from taking those medications, she would, try to get them back. But anyway, she didn't die because of the diabetic coma. She, we gave her sugar immediately. I gave her sugar immediately. Well, not sugar. I actually had glucagon. I gave her glucagon immediately. She woke up from that, but I had to take her to the hospital. Went well. She didn't die of that, but I'm just telling you that these are some things that could happen. Okay, moving on. So our nursing implications for polypharmacy, we must be involved in making sure that the care for our older adults is coordinated. As much as possible, we want to have communication between the different areas where she or specialties that she is getting care from. So some patient teaching may include, only use one pharmacy, that way that the pharmacy knows everything that you're taking. Maybe not the OTC drugs and maybe not the dietary supplements, but at least with the prescriptions, we all know the list if they use one pharmacy. If her patient is there in the clinic, I would, try to get a medication list and make sure it's comprehensive. Prescription drugs, herbal and dietary supplements, as well as OTC drugs. So maybe give that to the pharmacist. Another thing that I would do is that, bring the bag, like bring all of your medications so that we can check them out. Have frequent medication reviews with them and conduct medication reconciliation. Again, this medication reconciliation is about the technological way or the IT process of combining the medical record of the patient so that all of the healthcare systems will know what medications, as well as OTC meds and dietary supplements, is the patient taking. Okay, Beer's criteria was developed by the American Geriatric Society, and this is supposed to aid healthcare providers in safely prescribing and administering drugs to older adults. So they have revised this so many times, but the latest one, which is the 2015 Beer's criteria, they've added information regarding renal dosing of drugs as well as any drug-drug interactions. So this is a really helpful document. I provided you a copy of the Beer's criteria. You can browse through it, but I wanted to show you which drugs should not be administered to older adults, or which drugs should be used with caution. But again, also, that's not the only thing that you have to follow. You also have to consider individual preferences, values, and needs. With the older adult population, they're more likely to have a lot of adverse drug events. So 775,000 ED visits in a certain year was found to be related to older adults, and it was because of medication, adverse drug reactions. And out of this 775,000, 125,000 people were hospitalized. Research has shown older adults are twice more likely than younger adults to visit the ED for adverse drug reactions, and 7 times more likely to be hospitalized. And this is usually due to drug-drug interactions related to blood thinners, anti-diabetes meds, seizures, anti-seizure meds, cardiac drugs, and drugs used for pain. So, as we know, adverse drug events are unintended. We don't desire these effects, and this could be based on an adverse drug reaction like an anaphylaxis or a hypersensitive reaction. It could also be a result of a medication error. Could be a therapeutic failure, it's not working, or adverse drug withdrawal events as well as overdoses. And why are older adults more at risk? Because they're frail, they have multiple illnesses, they do polypharmacy, and they have cognitive issues. Another thing that we're looking at for patients is that we want to make sure that in older adults, adherence could be especially troublesome because first, they could not be as engaged in their care process. So although they're there, they may not know what questions to ask, or they may not ask during their interactions with healthcare. And so their drug regimen is not fully understood, so it cannot be precisely followed. Some of them just choose not to adhere to drug regimens, which could then lead to adverse drug reactions. Also, they may have complex drug regimens, and so they just like, you know what, whatever, don't need to do that. So the cornerstone of adherence is to provide proper education, in-depth education, and we need to include the family and any formal and informal caregivers so that pharmacotherapeutic adherence will be achieved. So what are our nursing implications to this? So we need to plan strategies, and we need to include the patient, the family members in planning out the care for a patient. We may need to contact them daily to kind of remind them, like, okay, you know, you have to remind, you need to do your, you need to take your medication. Make sure that their prescriptions are being filled at one pharmacy, and then we need to assess the patient's ability to obtain prescriptions before we send them home, because maybe they don't have transportation, or maybe you know, they can't be able to, they don't know how to obtain their prescriptions. So in a way, it's all about navigating the system so that we could help them get their drugs, get their medications, and make sure that they're adherent to it. So if they can't afford it, maybe try and find ways to get drugs for free or at a reduced cost. So these are a list of health teaching tips with older adults. So for example, when we're teaching them, we need to encourage them to use their sensory aids. Make sure that if they have hearing aids, they're wearing them. If they have eyeglasses, then they need to use them. We need to speak in a tone that the patient can hear, and then, you know, sit facing the patients, and that will help with limiting distractions. Don't infantilize patients. Treat them with respect, but treat them as adults too. Expect that they can learn. They're not, you know, small children. When giving patient teaching documents, use large print and put a dark type against a light background. Have a font with feet and tails. Okay. And then review all drugs at each patient visit. And as much as possible, ask them to bring all their drugs to their appointment. That way you can do a medication review and have a comprehensive list. Advise the patient to complete the Vial of Life, which is an online form. It's a medical information for emergency personnel. This form should be placed on the refrigerator door so that any safety or emergency personnel can be able to find it. Instruct the patient to keep a list of their drugs taken, including OTC as well as dietary supplements, to bring them all to their health appointments, and to carry it when they're out of the house, because they may need to take their medication when they're out of the house. Try to make sure that they have a simple dosing schedule, so you may have to look at it. If it's complex, they're not going to follow. So work with the patient as well as the healthcare provider to get a simple dosing schedule. And then maybe use those, adherence, some kits like the pill counter. that could help with adherence also. If the patient is confused or disoriented, suspect that they may be recently prescribed new drugs, in addition to what they already have. And if the drug does not help them in improving the condition, or if they're experiencing adverse drug reactions, then they should report it immediately as soon as possible. So memory aids such as pill organizers, planners, alarms, blinking lights, or pre-recorded message or text messages, if they are techy enough, can be used to help our patients with adherence. Okay, so this is the end of the lecture, and I know it's a lot of things, but the pediatric and older adult considerations, it's not really that much. So hopefully this will help you in preparing for that take-home exam or take-home quiz if you have. Okay, well, if you have any questions, shoot me an email, and I will try to respond to you as soon as possible. Thanks, everyone. See you next week. Bye.